my job now is to set the scene in terms of what's to come, in terms of identifying what the unmet need is for our patients, and to then let my colleagues talk about the solutions and the evidence base to support this proposed solution. Angina is probably one of the commonest symptoms that we see in our everyday clinical practice, and it is the commonest clinical manifestation of coronary artery disease, with an estimate of around 100 million people living with angina worldwide. And of course, it's important to say that this is not a condition that is restricted to the developing world, but the developed world. This is something that is really a global issue. And this is a fairly conservative estimate of around 10% of these patients continuing to live with significant life-limiting angina despite patients being administered either conventional medical or revascularization therapy. So this is a big clinical problem. And the problem is going to grow. The prognosis of ischemic heart disease is improving, so survival is getting greater. And in addition, patients are getting older, and therefore the burden of patients with complex coronary disease and continuing symptomatic angina is only going to grow. So if we think about a patient-centric approach, this is our patient with symptomatic angina. We know from a number of pharmacological studies and registries that the presence of angina seems to be associated with an increased risk of adverse cardiovascular events. However, we also know from important work from Tim Henry in Minneapolis when he was there from the Optimist Registry that these patients continue to live with their angina, but they don't die of it, with actually 75% survival at 9 years, which was significantly greater than we previously thought. So what that means is that people are living with their angina, and they're not dying from it, so they really have a rather miserable existence with these life-limiting symptoms. So we often take angina, we listen to our patients about the symptoms that they are complaining of, but we never really put ourselves in their shoes in terms of the way that angina impacts the way they live their lives on a daily basis. And it impacts their physical activity, their personal relationships, their family relationships, and of course, this incurs significant psychological comorbidity. So adding to the burden that the patients experience on a day-to-day basis. And this has a significant impact on our health economy. So we know that patients with symptomatic angina account for around 1.5% of our total healthcare spend, that the presence of ongoing symptoms increases that even further by almost twofold, and they are often attending their primary care physicians, they're attending urgent care centers or the emergency department, and if they do get hospitalized, the hospitalizations are often of longer duration. They incur significant additional investigation, which is often invasive, and that only extends the cost of the care of these patients, but the treatments that they're administered often make little difference to their future clinical trajectory. So when we think about the management of angina and coronary artery disease, we're focused on clinical trials and the endpoints of improvement of physician-adjudicated symptoms, failure rates from various revascularization strategies, and considering what types of pharmacological revascularization strategies we would employ for the management of these patients. But that is quite different from the patient view, who they're much more interested in what are the things that I can do on a day-to-day basis. So the question is, what solutions can we offer to improve the patient experience of angina? Now, of course, we take a very reductive stenosis-centric view of the management of ischemic heart disease, and that stenosis leads to various forms of dysfunction of the coronary circulation, blood supply to the heart, and the myocardial sequelae of that, ultimately leading through the ischemic cascade to the presentation with angina pectoris. However, we need to understand that the pathophysiology of angina is far more complex. Number one, it's not just the epicardial coronary artery stenosis. We have to understand the effect on the microcirculation, the interactions between the heart muscle and the microcirculation leading to flow, and then the perception of angina by the patient. And so we need to put all of these complex bits of sources of information together, leading to the patient actually developing their symptoms, and then also the levels of dysfunction that we're able to detect by various different means. So if we think about the things that a patient is doing on a day-to-day basis, we say, and patient objectives, actually they've got very simple objectives. Can I get about doing my daily activities? And we often find that things that they want to do, which are relatively simple by our standards, are often not able to be achieved because of limiting symptoms. So I'd like to personalize this for a patient who has come to my angina clinic. And we run a large clinic that looks after these patients with difficult symptoms. And her goals were simple. I want to be able to walk my dog. I want to be able to work. You know, she came from, a position where she needed to contribute an income to her family, and the inability was a significant source of stress for her. And she wanted to help with the care for her grandchild. Now, the thing that I wanted to emphasize is this is not a problem of the elderly. This lady was a 38-year-old woman, okay? And she was taking GTN between 2 and 5 times per day, with multiple previous attendances in the emergency room and unable to do the things that were listed here, leading to significant physical limitation and psychological limitation. Now, this young lady had multiple previous risk factors and aggressive coronary artery disease that had previously been treated by revascularization, and a host of other comorbidities occurring at a young age. And her symptoms were persisting despite the prescription of 6 anti-anginal drugs, despite all these previous forms of revascularization. And what we need to do is understand the patient's objective and use the different sources of treatment options available to us to, in combination, these things are not used in isolation, in order to be able to get the patient to the targets that they want to achieve to improve their quality of life. This is a patient-specific management plan. And we have to think, what are the options that we have currently for the treatment of our patients, and understand the benefits, but also the weaknesses of them. And the reality is, despite the array of different anti-anginal medications that we have, 70% of patients still continue to have limiting angina at 12 months, despite optimized medical therapy. In addition, revascularization is also not without its limitations. Between 20 and 40% of patients continue to have anginal type chest pain despite both percutaneous and surgical revascularization. So we need to consider our choices of treatment, and when we're considering the next phases of treatment, new treatments should be efficacious and address the symptom and the patient priorities. They need to be done at an acceptable level of risk, i.e. safely. The procedure should not incur significant morbidity, and the treatment effect should be durable. And the question is, how can we address some of the limitations of effective treatment? And I think I've clearly demonstrated that there is a clear unmet need for these patients. We need to demonstrate that our procedures are feasible and efficacious, and that they can be done safely for patients. So just to finish with the story of this patient. So she was a young patient who, after extensive discussion in our angina heart team, ended up with a reducer implantation. This resulted in a significant improvement of her symptoms. She was able to achieve the things that she wished to. And when we did follow-up imaging, we were able to demonstrate significant improvements in myocardial perfusion. Those are things that, the perfusion and the change in the CCS class, that's all terribly important to us. But what did it mean to the patient, well, actually, this lady's father, who was living with her, had a cardiac arrest. She was able to continue with bystander resuscitation for her father till the paramedics arrived without the generation of angina. And so the resolution of these symptoms really, I think, or this case indicates how important symptom improvement is in terms of improving not only the quality of life for patients, but also for their wider families. And now it's my colleagues will tell us how to do it. Thanks very much indeed.